All right, we're going to get started. So welcome everybody here in person and those who are online. I'm Abel Coe. I direct the Institute for Augmented Intelligence in Medicine. I'm going to get this out of the way. Adela reminds me, for those who are online, please use the Q&A, not the chat. So please use the Q&A and not the chat. And so I think our technical difficulties have been sorted out. So I'm incredibly honored and we are very pleased to have today Dr. Thomas Kannampallil. He is joining us from WashU, where he currently is associate professor in the Department of Anesthesiology. And in many ways, this is a little bit of a homecoming for Dr. Kannampallil. He actually had spent quite a few years here in Chicago at UIC on the faculty there. And near and dear to us, he was, I think, director of primary care innovation, I think, at that time. Since he's been at WashU and actually has gone on to many new directions. And in fact, one of the things we are really excited about his work, it is very much intersectional. So it intersects between things like workflow and burnout, but also has a clear clinical informatics component to it. And so we are incredibly excited to welcome him here today and hear about any number of the products he's doing, but he'll chose us a small sample of the products to talk about today. So please join me in welcoming Dr. Kannampallil.
So some of the things that I'm going to talk today is related to this ongoing grants that we have, multiple grants we have related to audit log work with Stanford, with Dave Schanefeld and Liz Harry at University of Colorado, and also with another grant from the National Library of Medicine with Julia Adler-Milstein from UCSF. So just to give, to put things in context, I want to give a little bit of a background where I came from. I was trained as a cognitive psychologist, right? Like essentially ran lab experiments trying to, modify things on the screen and looking at visual cognition. By a really chance encounter, I worked with Ted Shortlip and Vimla Patel about 10 years ago, or more than 10 years ago now, when my significant other Joanna was doing a postdoc with Vimla, and I didn't know what to do, and I ended up starting to work on this. At that point, ONC funded ARRA projects were related to the impact of health cognition. So, I learned a lot of stuff at that point in Sonar. I was literally an application developer. And, from my basic training, I knew a lot about reasoning and decision-making, which was my connection to Vimla. And then with sort of hands-on experience with EHRs, multiple EHRs during the time I worked with Allscripts, I worked with Epic, and I used to have till about 2 years ago almost every certification that you could possibly get as a non-physician in Epic. I didn't have the builder. I've let it lapse because they now have a 5-year period in which you have to retake the test. It's hard. And I've worked with a number of in a number of areas, but primarily my research areas are around clinical decision support and patient safety. And over the last 5 years or so, I've been in the Department of Anesthesiology at WashU, and specifically focused on perioperative outcomes. We have a big perioperative innovation center where we work on intraoperative telemedicine and sort of machine learning and predictive algorithms that can help intraoperative surveillance. So I'm not going to talk about any of that today. Today, I'm going to talk about clinician workload on burnout using EHR-based audit logs. Has anybody here worked with audit logs? Dr. Linder has. I know I've talked to Yang about some of these measurement. The thing about audit logs is that it started as it is a mechanism of measuring or keeping track of patient privacy within the EHR. It was regulated from the 2010 ARRA rules. For meaningful use of EHR, you needed to have a mechanism to audit access to the EHR. And it was always seen as a security mechanism, who touched whose record when. But over the last 5 years, with physician workload being an important consideration for how people work, its use has transformed. But before I start my various experiments and studies that we have done, I want to caution, this is essentially a proxy for work, not a full capture of work, but it is a really good proxy for clinical work. So why is this? Why has this taken an added importance, especially in the last 4 to 5 years? The 2019 National Academy of Medicine report, which talked about the burden that physicians face. Almost 50% of the time in the time that the physician does, especially for certain specialties, especially for primary care specialties, spent in the EHR. We talk about significant challenges of pajama time or work outside of work that's associated with clinical work. One big reason for that is in the modern clinical environment, 100% of the clinical work passes through the EHR, whether it's orders, documentation, other aspects of work. And this is a significant challenge because the problem we are trying to solve is how do we better study clinical work? And it really has an impact on a number of aspects of a physician's life in terms of just the pure clinical workload on how much work you're doing, the cognitive burden associated with working on the EHR, like interruptions or the multiple things that you're doing, burnout, which is again a multifactorial construct, but again related. Several of the studies have shown associations between EHR-based workload and burnout. And then the problem of COVID and the modern clinical or the healthcare administration world, turnover among both physicians and nurses. And a lot of the exit surveys have shown the documentation burden is a key contributor to these sort of things. I'm not going to talk about turnover. Some of my colleagues at Yale have started this program on looking at, Ted Melnick has started looking at workload-based measures and turnover. They have a recent paper out. So there is considerable work in all of these areas. So the question really became, as I started in this talk, about how can we study this workload? There are I was having a conversation with Yu Yang this morning, and we were talking about what is an audit log. An audit log, in its pure definition, is a security construct, right? Who accessed which log when? It's mandated specifically for audit log for security reasons, and it's captured whenever a patient record is viewed, modified, or accessed. So it's not a true sequence of everything, but it essentially gives you, it tracks who performed what action on which patient. So if you look at the table on the right, it's a de-identified pre-op sequence. So you can see there's a time attached to that, and this person with the user ID is looking at a pad ID, which is a de-identified version of us, a version of Epic's MRN. You can see this person was looking at patient charts. They were going, when they logged into that one patient, a lot of things, automatic things got loaded. Then they went into a chart notes tab, review tab, did a bunch of things, and then went away. So it's not great, but it gives you a sequence of events that happens. And the one thing I want to add, and I'll get into this, you can attach, this is the largest table in Clarity. So it's called the access _log table. The access log table at WashU, which is running at for about 5 years now, 5 years since Epic, has 28 billion rows. It's the biggest table. The complexity of the audit log table is not just the number of rows. It's trying to come up with what exactly the type of note this is. For that, you have to join to other tables that will tell you that this is a procedure note. These joins are basically which kills your queries, right? So the point is not to understand audit logs alone. It's the point is to understand the building a structure around audit logs that you can better contextualize the actions that a physician is performing. So that's sort of a background of audit logs, right? Essentially, it is a fingerprint of clinicians' work. There's lots of work done since the last 6 or 7 years where this became a sort of a semi-hot topic. Mark Overhage at then Cerner did comparisons in outpatient versus inpatient care. Most of the studies that I want to highlight has been on descriptive studies on characterizing work. But I think what I'm going to talk today is about we can do better with trying to associate it with outcomes. And Julia wrote this a perspective on how this can become a very prominent source for data for health services research. But I wanted to take a minute to highlight one other part of what audit logs mean. The term is really confusing. People have used it to mean anything to do with actions that are logged in a computer. But it has specific meanings. When I'm referring to audit logs, at least for the stocks, I'm talking about essentially the raw events that happened. But what Epic considers audit logs is a broad set of things. I'm not going to go into their nuances, but one of the things that people often say when they say audit logs is the signal. Like if you're an Epic instance, you have an access to these aggregated measures called signal measures. So you want to see, in comparison to Dr. Ko, how Dr. Linder spent time in performing, terms of orders or review time or in-basket messages. It's a really useful tool if you're a CMIO or a wellness officer to identify sort of gaps in your work. It's great, except it's really easy to use metrics, except there's no transparency. That Epic just tells you this is what it is. There's studies that have recently shown from Stanford that it actually overestimates the time that it actually gets. But if you're looking at longitudinal studies, it's great. Much of the initial studies with audit logs have referred to them as audit logs, and compared to different outcomes. It's I want to acknowledge that it is a prominent area of research. But in contrast, like I said, this is the raw audit logs provide much more nuance. It gives you the sequence of work. It gives you the structure of action. So that gives us some opportunities to work with to get better insights about this. Like I said at the beginning of this talk, right? Like the thing that motivated me towards looking at this data set was the National Academy of Medicine report. The National Academy of Medicine report from 2019 basically came up, Pascal Carrion was the lead on that report. It was on reducing action against clinician burnout, and then the pandemic hit, and then, it was just right before that. And the idea was a very systems-based perspective of this, right? Like, can you look at burnout from the construct of individual factors and work-related factors that in a health system, and look at outcomes that happen as a result of that? A very simplistic structure. So what we try to do in all of our studies is try to essentially base it on these frameworks. So what we try to do with audit logs is to look at essentially iteratively build work-related factors from that. So for example, things like type of activities that people do, patient complexity factors, interruptions, EHR-related factors, workload-related measures that we can develop from, in terms of dimensions of EHR work. You could also, we started to look at individual factors, not that much, but mostly at the level of individual clinicians. In some of the studies, we try to look at several personal factors and characteristics of that, and then use these as the basis for predicting or assessing associations with both errors and burnout. We essentially published our the framework that we thought was appropriate for using audit logs as the framework. So today I'm going to talk about three different things. How we used audit logs to create measures of both workload and cognitive burden, and then how we use those metrics and measures that we created to study both medication errors, specifically wrong patient errors, and then also with burnout. I'll also talk about a little bit about our unsuccessful efforts to build machine learning algorithms using audit logs to predict both of these outcomes. And there are some interesting lessons to be learned as we go forward with this. All right, I'll pause for a second if there are any sort of quick questions before I go into the studies. All right, so the first study I'm going to talk about is the study that we did on measuring cognitive burden. So attention switching from studies in psychology have shown if you're switching between dissimilar tasks, it slows down your task on the post-switch task. So let's say I'm asking you to count numbers 1 through 10, then suddenly ask you to stop and count backwards from Z. The switch task, because of the dissimilarity between the tasks, creates two sort of problems. One, it slows down your post-switch task. Second, it increases the chance of errors on the post-switch test. Very simple, and it has been shown in a number of switch and non-switch trials. And the results have all been consistent. There's been variations in this type of trials. So we decided to do the simple study with audit logs to study if the task switching, yes, Justin. For sure. Effects last. Correct. So it is, the effect is on the post-switched, immediate post-switch task, and it normalizes over as you get into the new task, right? Like it's not like a consistent thing, but the key idea here is that the switching causes a slowdown. So there are sort of fundamental theories that you can draw from. So in the case of, in our case, from audit logs, it's really difficult to demarcate what a task is, because so what we decided to do is we decided to look at switching between patients in an uninterrupted sequence of events, right? Like, so you're going through a set of tasks and set of EHR-based actions, and you're switching between patients. We defined it as a patient switch. And the reason for doing that is that, does it increase the total time that you spend on the EHR if you switch more versus less? Or does it increase the likelihood of errors? Essentially, the metrics that we were trying to look at was there decreased efficiency in terms of downstream effects, in terms of total time spent, or whether also an increased likelihood of errors. And if you look at the studies that have been done, essentially, Johanna Westbrook ran a series of studies in the ED on looking at interruptions and post-interruption tasks with a time and motion type of study, very small sample, but have essentially shown these sort of interruptions delay the task. But the preciseness of the measurement of those and the scale have been much smaller, not saying the results were any different. So how do we define attention switching? So what you see here is a sequence of tasks, a sequence of actions on an audit log. You can see that was on one, this is all for the same user. It was on one patient, then it went to patient B, and then went again. But at some point, you can see that there is a 9-minute gap. We used, based on a series of studies that I'm not going to go into, that a 5-minute interval was an approximate metric for person having not been at the computer, right? Like in terms of inactivity. So you can say that 5-minute is a new task. So what you can see in that uninterrupted period, this person spent 4 minutes and 21 seconds on one patient, moved on to the next patient. So we considered that in that uninterrupted period as one attention switch during that period. And what we were looking for is to look at the relationship between attention switching and work efficiency, which we measured by total EHR time, and errors, which is, we used a metric called wrong patient errors, which is a ONC, which is a standardized measure, which is and it's a standard measure in Epic now. If you order a drug or an image or any order on a patient and cancel it within the first 10 minutes, reorder it on another patient within the next 10 minutes, it has a over 85% positive predictive value of being a wrong patient error. It's a very specific type of error. It's not a true error because it's a near miss error. It's an intercepted error, but it's often considered an error because of cognitive distractions. So we ran the study, we picked out a unit to study. I'm in anesthesia, so we did 4 surgical ICUs. These were staffed by both APPs and physicians, and also residents. We did not include residents because both surgery and anesthesia residents rotate through here. So we did both the APPs and NPs. We did 1 year, 2019, 18 million audit log events, about 60,000 hours of data. So this is what I mean by scale as opposed to a time and motion study. It's easily scalable in order to study this. I'm just going to jump into the results. We had about 95 participants during this time. Lots of shifts, mostly managed by APPs that you can see here. And we computed a bunch of measures. So for example, the total EHR time, the after hours time was very low because most of these people used that it was a shift-based work. You can see the density of the activities, both attending physicians and APPs here. The 18 is just not the actual time scale, it's the 12-hour period. So we just average between night and day shifts together. You can see immediately after the density of EHR activities, immediately after the shift started, it increased and it went down. But for and then towards the end of the shift, it again increases, just to give you the density of the activities. So what did we find? We ran a bunch of mixed effects, linear mixed effects models to look at the differences between in the rate of attention switching and increased and EHR time spent on the EHR. For APPs, we found that an increased rate of switching from the 25th to the 75th percentile increased the daily total EHR time by 0.28 hours, which is about 40 minutes. 17 minutes, sorry, or approximately 7%. And then for more concerningly and interestingly, the increased rate of switching increased the rate of wrong patient errors by 28%, which was a significant increase. The couple of things that I want to say, attention switching, so there is a lot of work, especially Krasinski, who's at AMA, who's really interested in developing these metrics for EHR-based metrics, or just the metrics from audit logs. And there isn't a good one for cognitive burden. So we do think that the attention switching, at least, is a preliminary metric for assessing cognitive, especially probably not in outpatient practice, maybe in inpatient practice where you have to deal with multiple patients at the same time. There are some limitations. We do not know why they switch attention. This is again one of the core deficiencies of audit logs. We just know that if it was, we don't know if it was by their own volition or by an external factor. But again, this was a preliminary study. I do think that the attention switching metrics provides a basis for future studies as a metric. You know, there are several people I've talked to about replicating this in the ED, where the physicians see multiple patients at the same time. I want to say one other thing. All of our code, except for the Epic Clarity queries, are on GitHub for all the processing. Happy to share the Clarity queries also if somebody's interested. So the paper was published last year, and then I want to move on to the next set of studies, which was essentially looking at burnout, essentially using. But I want to pause for a second if there's any questions on attention switching. Yes. Correct. Different. Correct. And Epic does 4 upgrades every year, depending on the sequence in which Northwestern is on in terms of the updates. We're on a 9-month delay, but I'm sure. Yes, Della. Oh, I can just repeat. So the comment Dr. Linder made was there's a lot of upgrades on Epic, and that actually updates, not upgrades, updates on Epic, which essentially messes up the physician's workflow and sequence, which increases the cognitive load at the end of the day. So, Adela, yes.
So a question from our online participants. Interested to know if attention switching ability has a large variation across different individuals.
I'm going to say yes. I don't know empirically if that's the case, but again, this probably is a practice-based construct. So, for example, I have seen in observational studies that certain physicians, so for example, physicians do several things, like for example, before morning rounds, they do several patients' history and physical together. Which means that you're switching between multiple attention switches at the same time. Several others, maybe trainees have done a patient at a time, which increases, right, like creating a complete picture of a patient. So there's likely to be significant variation. Yes, Steve. Advanced practice providers, sorry, they're nurse practitioners with independent. All right, so I'm going to move on to the studies of our studies of burnout and outcomes related to burnout. So I don't need to repeat this to this audience. 50% of practicing physicians face burnout. It's increasingly higher among trainees and also medical students. It's a significant problem. It's been associated with turnover. Everybody's talking about it, and there are no solutions besides, there are no specific solutions that have been designed. We also do not know burnout very well because it almost invariably uses a survey instrument to measure burnout. So if physicians don't fill out surveys, you do not know who's burned out. It's a significant challenge. It's both a measurement challenge and it's also an intervention solution challenge. So what we thought about was, what if we could use audit logs to screen for burnout? If workload, as has been said, at least in perspective and opinion pieces across the board, EHR causes me burnout. If that's the case, these audit logs or event logs should be able to tell us something about the signature that's associated with audit logs. At least that's where we started. So the purpose was to create some sort of a digital phenotype of burnout, just as you would see in using Fitbit or using clinical data. So you can think of burnout as being in terms of behavioral markers, things like workload, and what elements of workload cause those cause burnout, and can the patterns of EHR use be used to study that? So we believed, at least strongly, that the patient factors and the total EHR time and sort of the metrics that we have developed could potentially be a marker. Similarly, temporal features like patterns of use, attention switching, number of patients can be a marker. So that's where we started with. So for this, we did a prospective study for over a period of 6 months. When we started the study, this was just when WashU had reopened its studies, recruiting participants again for studies, October of 2020, September, October of 2020. And the only people we could realistically do for the study was trainees. So there's lots of challenges with doing with physicians. In an ideal world, I would have done this with attending physicians in outpatient practice because of the stability of their practice from day to day and month to month. So anyway, so we recruited. There were 104 eligible interns in medicine, pediatrics, and anesthesiology. Anesthesiology interns in the first year do medicine. So just like other in medicine and pediatrics. The one thing I want to say is that if you've read trainee studies, the average response rate for trainee studies is between 15 and 20%. Our response rate was 77%. And I'll tell you a secret. The secret was instant gratification. Every time, all they had to do was to fill 6 surveys. Month to month, they had to fill this burnout survey. And the moment they filled this survey, they got a $10 gift card. Like the moment. You get an email with a gift card link. And it took 5 minutes to fill the survey. And our overall response rate was so high that it was shocking to a lot of people, even when we reported the study. So again, I'm not saying this is wrong or right, but this is a way to do this. So we built this entire infrastructure around automatically collecting this data. So essentially what people had to do once they consented to the study was to fill out, we'll get these monthly surveys at the end of their rotation period, and they'll fill out this a PFI survey, which I'll talk to you about. And we continued it to 6 months in the sense that we thought that the longitudinal measurement was going to give us some insight on how things work. So again, our primary outcome was the burnout score using this standard survey scale. And also we looked at a secondary outcome of wrong patient errors. So the survey scale which we used was called the Stanford Professional Fulfillment Index Survey. Mickey Trockel and Tate Shanafeld developed this survey in about 5 years ago. It's a relatively new survey. The advantage of this survey, as opposed to the traditional survey, which is called the Maslach Burnout Inventory, the MBI, which I'm sure all the physicians here would have filled at some point in their lifetime, it's a 1-year scale survey. In the past year, you had to answer questions about emotional exhaustion and depersonalization. The thing about this survey, it's a 2-week survey. It's asking in the past couple of weeks, past 2 weeks, what happened. The emotional exhaustion and the depersonalization components track are associated with the same measures in the MBI. That's been validated in terms of, it's been validated. And then the scale of 1.33 was used as a cutoff for being burned out. And I want to say there's a national consortium of academic institutions that you can sign off to and pay Stanford, I don't know how much, $35,000, $40,000 for them to administer this survey, which they'll keep separately and in a de-identified fashion. And if you want to use it for research, they have an honest broker in between that you can get the data on. And there's all sorts of things that are associated with it. So again, it's an academic survey instrument. It's free as opposed to the MBI you have to pay. So we used a PFI, and in terms of our design, every month participants completed the survey, and that's all they did. They agreed to give us their audit log data for those 6 periods a month. So like I said before, we had created this pipeline of using a number of metrics to measure what they were doing, like total EHR time, after hours time, number of patients per day. I also want to say that the interns had a cap on the number of patients they can see on a given day. So there were some caps in some of those things. So what did we find? Burnouts changes a lot and among people. The mean absolute change in burnout from month to month was 0.3, but that was not the interesting part. One interesting part that we saw, you see the red line here, that's the burnout score changing. What you see in the other colored lines are the total EHR time, the patients per day, the light blue line, and the gray line is the review time. Essentially, how much you worked affected what you perceived your burnout to be. The lines tracked. What it also showed is there is a considerable, and if you look at the top, it also shows where they were working. Inpatient versus clinic, where the workload decreased, the burnout decreased. So interestingly, we thought that burnout was essentially an elastic phenomena, and there might be, or there is very likely inter-individual variations in terms of what they considered as workload too. So that makes it a much harder problem to study. Anyway, so what did we find in terms of association with workload metrics? We found that the total EHR time, the patient load, and the review time were associated with burnout, not surprising. But we did not find an association with wrong patient error, primarily because there were too few wrong patient errors that were that happened during that period. Hard to say. Pediatrics had a lot of outpatient rotations, and which made it a little difficult to capture some of these. Anyway, so the work hours and the patient complexity / efficiency metrics probably were contributor to burnout. This was interesting for us in a couple of ways. This gave us some signal to say that, hey, workload-related metrics are potentially associated with burnout, and we could potentially predict them with machine learning models. And that's where we sort of went next. Before I go there, this was published in JGIM last year. We've got a lot of questions from different people in the country of whether they could use the code. I've shared this with many people. Again, happy to give the GitHub links on how to process this. So transitioning on to how to predict some of these things, there was hope. But what we wanted to do was not predicting burnout in a sample, but will this individual person be burned out, which is a much harder prediction to do. So we did what's called a nested cross-validation in terms of trying to predict for that individual. And I'll skip the details on how we designed it. Essentially, we wanted to use workload-related measures from set of features that we have and sort of temporal features that we created with off-the-shelf algorithms. And lo and behold, we did not predict really well. And there's a lot of reasons for why it didn't predict very well. It was disappointing. It was slightly better than chance. And the reason for slightly better than chance is several. One, there's a significant inter-individual differences. Just like I said, if Abel works 80 hours, he's cool. If I work 40 hours, I feel stressed, right? Like, so that difference makes these models confused. The second part of this is that we did not capture anything about what they were doing outside of work, right? Like, so, the situations that contribute to burnout were also harder to measure. Probably the most importantly, the interns were not a good sample for this. They moved from rotation to rotation. The rotations had different levels of stress in terms of workload, which makes it difficult for the models to get super confused about why is this person going from in terms of the association, in terms of workload and burnout. But here's the interesting part. We just used the first survey score to do the prediction, and it worked well. So if you add the workload measures in addition to the workload score, in addition to the survey score, it didn't improve significantly. So again, I do not think, and I'll come to this later, I do not think it was primarily because of the problems with the model. It was primarily because of the model problems with the sample. If we reran, and I'll talk a little bit about that, Stanford, a colleague from Stanford is replicating this with outpatient clinicians in the exact same code, and the initial results are in the 0.85 range, which shows consistency. In it's possible. It's at least a signal. We did publish this paper mostly as a lessons learned in terms of how to use audit logs for these sort of prediction tasks. I was talking to somebody this morning, and I was saying, what is the role of deep learning in the age of ChatGPT and these sort of meshes, which essentially use language-based models. So what we tried to do was essentially try to build these sort of a language-based model in order to translate action events into a model. So sort of like the word-to-vec model, how close an action is to similar actions, can you use that to predict the events? So there were so many big challenges in terms of understanding the RNN models can't handle long sequences. On a daily level, there's about 3,000 events for a person. So we had to compress this into a fairly complicated temporal convolutional network that was set up in based of individual day actions, which were suppressed into a month, then which was hierarchically set up into, because the burnout survey measures were at a month level. So you had to compress these 30-day events into a single month. Again, this is done by my colleagues in computer science and a PhD student. So the models, as expected, did not perform significantly better. I would have been shocked if it did, which is good validation for us in some ways. But the model gave us the idea that these meshes can be embedded with these sort of language-based sequences. And this, again, is something, if we had a much more consistent sort of work process, we could do it. This was published in SIG-KDD last year. This is one of best of the SIG-KDD for the model aspects. So again, I don't want to overstate the value of or understate the value of machine learning for machine learning in audit logs, but it is a challenging area. It's a proxy, but it does give us a window into how we can study some of these, predict some of these outcomes. There is significant individual variability which needs to be accounted for, and if you look at maybe much more stable practice in family medicine or internal medicine, it's potentially possible. We also want to look at better outcomes. I know folks here, Bruce Lambert and others, have been looking at abandoned orders. That might be a better, more significant measure for looking at these outcomes because it's much more common than the wrong patient errors and might give you a better association metrics. So I again want to come back to this. What I presented is essentially one small part of this, but if we keep this broader framework that the National Academy of Medicine came up with in terms of a system-based framework, we should be expanding these audit log-based studies based on expanding the workload-related factors. What sort of individual factors can you add into these models to make these models more comprehensive? What sort of outcomes can we consider besides errors that we did, like abandoned orders, or are there secondary measures, turnover, that we can consider within this framework? So I'll take another 5 minutes to sort of wrap this up. So we've done a lot of work. This is a promising area of research. Epic does not see this the same way. We've struggled to have traction with them in a number of areas. They don't release their algorithms, so we don't know what they're measuring or how they are measuring. So there is a divide between academic research in using audit logs and what Epic sells it as a product to CMIOs and hospital systems. So there's that. So from an academic research point, what's next? One of the big challenges, and we talked about this, what's a task? The raw audit log events is really, really noisy. The folks at Vanderbilt have started to look at clustering methods. So we used the action embeddings approach to see if we can cluster those events. It's a really starting point. It's not very clean. One of my PhD students has started to look at what's called diffusion wavelets, which is an idea where you can, idea of harmonic analysis, which is in addition to the sequence of the events, you can actually embed the time differences between the events to see some structural property aspects to that. So that's a promising area of research. Right now, we don't know when a task ends, when another task begins. And if we can even approximate some of these things, we get better fingerprints into work processes. And that has a significant potential. We've also started to think about what are pragmatic applications of using audit logs. With Julia Adler-Milstein at UCSF, we started this project, which is funded by the National Library of Medicine, to look at the effect of telemedicine on EHR work. Specifically, we're looking at two things. Are there differences in EHR-based work activities between face-to-face and telemedicine encounters, especially during the early phase of the pandemic when these were implemented? Is there more search? Is there more documentation? Are there more orders? Is there a specific sequence of events? Is the task switching higher in one versus the other? Are the number of messages in terms of specific outcomes? Are the number of messages higher? Are there is there low value care sort of orders, like imaging orders for back pain, things like that? So essentially, this is most into understanding sort of workflow in terms of pragmatic application in order to make some of these interactions better. Epic's been involved with some of this work, especially in trying to come up with the metrics. We're also using the basic audit log structure for this. There's also, and I don't know if there's an anesthesia, there's somebody from surgery or anesthesia here. I do think that the audit logs also provide an exciting opportunity to study reimbursement, especially workload association with reimbursement. So we did this study. This was actually our first study. It took forever to do because we didn't have billing data for the longest. Anyway, so 6 months of data from 160 anesthesiologists and CRNAs, about 10 million audit logs. We started to look at, do the actions that are performed in the EHR during surgery, and I know it's an approximate proxy for workload. Is it associated with the money, with the reimbursement? Essentially, there are three measures in which anesthesiologists are billed. So it's the time units. It's the time between the anesthesia start and anesthesia stop. There's a standard procedural base unit. So if you're performing a thoracotomy, you get a specific base unit charge that you get. This is a procedural base unit. And then there's an ASA score modifier. An ASA is the level of sickness of the patient. An ASA level 0 or 1, the patient's very healthy, and a 5 is very ill. So it essentially is a patient complexity. So what we try to do is we try to compare in a very complex statistical model that I cannot explain in a couple of minutes, or I may mangle that. Essentially compared whether there were differences between these metrics based on the time units versus based on the billed units for about 31,000 cases. And we found, essentially, if you ignore everything else, what we found is that, based on just the anesthesia billing, anesthesia faculty or providers are undercompensated for procedural complexity, which makes sense because if a patient's really complex, you got to do pre-op work like reading the chart and performing certain things before, but they overcompensate for the procedural complexity because a really sick patient actually requires more work than a stable patient on a complex surgery. Again, the point I wanted to make with this is not the specific result. This paper is almost accepted at JAMA Network Open. it's the pipeline that we can use these audit logs as a metric for comparing to RVUs in sort of any sort of care process. And the pipeline becomes an easy way to do that. I also want to end with this with this little thing that we just started doing. One of the things that the potential for this, and I know Northwestern doesn't use SecureChat, WashU does. SecureChat is essentially instant messaging in Epic, integrated in Epic, right? I know what Northwestern uses, Vocera. Is that Vocera? Pagers. Okay. Okay. Right. So Epic will try to tell you you should be using SecureChat. SecureChat's just like an instant messenger inside Epic, where you can find people and send messages. Just to give you a broad idea, this is a few months ago, about 1.5 million messages a month. There's lots of variations. The messages are mostly sent between nurses and physicians, or physicians to nurses in both those settings. But the interesting part of this is the point I want to highlight here, the message read latency. These are interruption events. Essentially, 29 seconds before when a message is sent, irrespective of the provider, when it's read, when it's responded, it's approximately 2 minutes, but it essentially gives you a picture of healthcare workplace interruptions. And the reason I think this is important is when you overlay this with audit log events, now you're able to characterize when people are interrupted, what tasks they're doing when they're interrupted, what happens as a result of this. And this provides an interesting basis for future studies. I mean, this is a goldmine in terms of how we can study. I'll also say I have spent the last 6 months working with legal on how to work with SecureChat, essentially legal, because you cannot, this is not, it's not a stored part of the, it's not part of the legal medical record. So it's deleted every 30 days. So I do not have the content of the messages. I only have the metadata on the messages. And if I store it, it can be discovered. It can be part of a discovery process. So we've not stored it, but technically somebody's going to do it. We'll have to figure out, NLP mechanisms to create it. But again, the point I want to make on all of this is this becomes another part where EHR is now used as a communication medium. How does that affect work practices, workflow, behaviors, and outcomes, so to speak? So the question is, what are the opportunities? Julie and I wrote this editorial but a couple of months ago. Again, this is we've moved beyond single site studies for audit logs. It's time to run these studies at 10 sites and 15 sites and 20 sites. And where we combine this data, and our HRQ grant's doing 3 sites, and it's been a legal hassle, but we've figured it out. We've figured out infrastructures. And if you want to run a pan CTSA grant of this sort, that's where I think the influence is going to be. There is a significant lack of common data models in this space, right? Again, I do not know if a common data model is needed for such a simplistic data, but because of the lack of agreement across researchers even, on how to do this, this is an exciting potential. And I also think that researchers have generally not shared their data, and we started with the idea that anything we do has to be put in public space. So I've told my students that any code that's been written has to be, other people should be able to use it. So more researchers need to come up with ways which we put in a common repository. I mean, research quality code, we all know the quality of research code, but we need to move forward. If we need to move forward, that's needed. I also think that we're at a point where we can develop phenotypes of activities, and that's where I think the rubber meets the road, and will make significant progress. This is not all my work. This Sunny Liu, who was then a cardiothoracic fellow, postdoc, and led most of this work. And I have a lot of colleagues, and the slides were adapted from several of the presentations we've done before. And I'll stop with one little story. And I said in the beginning that I like history. Does anybody know what John Lennon's elbow is? The history of John Lennon's elbow? No. So I promise there's a metaphor here. So John Lennon, so the Beatles concert in the 60s got so popular that people started singing and yelling at the crowds that nobody could hear the sounds, right? So in 1965, when the Beatles were playing at Shea Stadium, John Lennon decided, what the hell, and started playing the piano with his elbow. The product was awful, right? Like, but nobody could hear it. So nobody cared, right? And that's exactly the situation I think we have with EHR documentation burden. It's so bad. And the burden, even with lots of initiatives, but nobody can hear it, or we have no good ways of measuring it. And that is the problem we face today. And I'll thank you for the opportunity to be here. I really appreciate it. I'll take any questions. Thank you.
Thomas, that was fantastic and really exciting and very timely work. So we have time for some questions. And I can probably bring the mic to you.
I love this whole area of work. And actually your comment about the audit log data reminds me of what we always say about claims data, that the quality is terrible, but there's just so much of it. So one thing I keep getting stuck on with audit data is just an endogeneity problem, right? And it's the same problem with signal, right? That the signal data where you show somebody how they're using the EHR and you're sort of, you're using it badly, or you're using it too much and you're using it wrong. And it's very punitive seeming. And it's hard to sort of come up with solutions, but the same
applies here.
What's that?
The same applies here.
Yeah, but and by the same token, we're sort of looking at the EHR usage log it's in the causal pathway of why people are getting burned out, right?
Right.
And so it's not an independent construct that you can sort of change and then affect the burnout necessarily. Like
yes,
it's this endogeneity problem that I keep running into.
No, it's a significant problem. The question is, okay, we found out somebody or a set of people are going to be burned out because based on their phenotype. What do we do? And I think that's a big problem. So the HRSA just funded a big national project on burnout interventions. And I'm not a burnout expert or an intervention expert, but I think that's where the purpose here is to identify and connect. And how that translation happens is still a problem, right? And I agree. If you tell people to do more yoga or mindfulness exercises, they're gonna, exactly, right? So. I don't have a good answer for that. I do think that the space that we're in as informatics researchers in this space is to identify the weak links in the process to characterize the problems. And I think this is where a truly collaborative effort is required. And I want to say one other thing. Like, we're in Chicago, AMA's here, Krasinski runs a big program on EHR use burden, and I've worked with her for the last couple of years. She's great. She thinks about these problems, and the AMIA has a 25/5 reduce documentation burden by 25% by 2025, which is also coming up with sort of structured ways to reduce it. Again, I don't know if any one of them is going to be a solution, but I do think that the solutions are local. I don't think there's one thing, right? Maybe scribes work in certain areas. Maybe certain other kinds of interventions work. So, no, it's a really good question.
Yeah, we have a question online. On the individual level, who are the outperformers? Do you think that ability to resist interruption and multitasking are trainable? How about on the system level, what kinds of interventions would be important?
Right. So, let me speak about what I have thought about in terms of interruptions, right? I think Epic has a huge role to play in reducing interruptions. So let's take the case of SecureChat. If you're in when can you make ordering errors? When you're in the ordering menu. Can we queue the messages when you're in a certain space, or because right now the messages appear as they come. So there might be design interventions that can reduce some of that. The other part of this is that the big challenge when I talked about attention switching, the problem is it's not just the attention switching. It is coming back to coming back exactly to where you left off on the previous task, which is the bigger documentation, but the bigger burden. How can we build design interventions that can give you the locus of your previous action or a set of previous action, right? Like scrapboards and things like that. I don't know. So the solutions are potentially design-based on the Epic side rather than sort of training interventions. Maybe there is potential for certain kinds of ways in which you should look at, patient charts and stuff. But it's in a very busy clinical environment, all of that goes out of the window.
Great. And with that, we're at time. Thank you so much, Dr. Kannampallil. Join me in thanking him, and we look forward to lunch.
Thank you.